Everyone, my name is Leah Gibbons. Today I'm going to be doing a presentation on exhibitionistic disorder, also known as exhibitionism, which has the DSM-5 code 302.4 and the ICD-10 code F65.2. Exhibitionistic disorder is listed under paraphilic disorders in the DSM-5. There are two criteria for exhibitionistic disorder. Criterion A, over a period of 6 months, recurrent and intense sexual arousal from the exposure of one's genitals to an unsuspecting person as manifested by fantasies, urges, or behaviors, and criterion B, the individual has acted on these sexual urges with a non-consenting person, or the sexual urges or fantasies cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. When making a diagnosis of exhibitionistic disorder, clinicians should specify which of the three subtypes the client falls under. The three subtypes denote the physical maturity of the targets. These subtypes are: the person becomes aroused from exposing their genitals to prepubescent children, that's a synonym for prepubertal, to physically mature adults, or to both prepubescent children and physically mature adults. Clinicians should also specify whether the client has exhibited these urges and behaviors in a controlled environment such as jail, prison, or a mental institution, or whether they are in full remission. Clinicians should note that full remission does not mean that the person has ceased to be an exhibitionist, just that they are no longer acting on the urges, or the urges no longer cause clinical distress. When diagnosing exhibitionistic disorder, clinicians should be aware that the disorder may apply to both individuals who freely disclose this paraphilia, as well as to those who deny any sexual attraction or arousal from exposing their genitals to unsuspecting persons, even if there is substantial evidence to the contrary. However, the individual must be experiencing distress, such as anxiety, obsessions, guilt, and shame, or causing distress to those around them in order to qualify for exhibitionistic disorder. Diagnosis of exhibitionistic disorder hinges on whether or not the individual is experiencing distress, or whether the exhibitionist behaviors cause stress to others around them. If an individual experiences no distress surrounding their exhibitionism, they do not meet criterion B. If the individual is not impaired in areas of functioning such as occupational, familial, or social interactions, and their self-reported psychiatric and legal histories do not indicate that they have acted on their urges, then the individual displays exhibitionistic sexual interest but does not qualify for exhibitionistic disorder. The history of exhibitionistic disorder is longer than one might expect. Jean-Jacques Rousseau, who lived from 1712 to 1777, was one of the first recorded exhibitionists. Exhibitionism was first used in the English language in 1879. The German psychiatrist Richard von Krafft-Ebing was the first to popularize the term exhibitionism with his book Psychopathia Sexualis in 1965. Early psychoanalytic theories about exhibitionism posited that it might stem from a denial of castration or sexual desire for the victim. Later psychoanalytic theories suggested that boys who had seductive, flirtatious mothers were predisposed to becoming exhibitionists. Some theorists thought that exhibitionism was a response to fragile masculinity and an attempt to exert power and domination over women. Cognitive behavioral theorists suggested that exhibitionism was reinforced by the sexual arousal and orgasm gained by fantasizing about or acting on exhibitionist urges. Freud, Cito, and Cuban suggested that the exhibitionism might be an atavistic trait that stems from the mating rituals of animals. Other theories include the vulnerability model, which integrates cognitive behavioral theory and attachment theory, and suggests that insecure attachments to parents generate poor self-image and maladaptive coping mechanisms. The vulnerability model suggests that people turn to exhibitionism as a way to cope with stress and loneliness. The prevalence of exhibitionistic disorder is unknown, as people with paraphilic disorders are a difficult population to study, as there is a lot of shame and stigma surrounding these disorders. Exhibitionistic disorder also cannot be diagnosed unless an individual self-reports their urges and distress, or unless the person is arrested in connection to an exhibitionistic act. The DSM-5 estimates that between 2 and 4% of the global male population qualifies for exhibitionistic disorder. Women are not well represented in the research on exhibitionistic disorder or in the research on most paraphilias, as it is believed that women are far less likely to have paraphilias. However, recent studies have questioned this and have exclusively looked at exhibitionism in women. We will look at one of those studies in a later slide. Since many exhibitionists are not exposed as having these urges until they are arrested, Much of the current research has been done on incarcerated males. As for the development and course of exhibitionistic disorder, most male exhibitionists report first experiencing urges in adolescence. There is no minimum age requirement for diagnosis, but clinicians should be aware that exhibitionism in young children and adolescents may not be indicative of a disorder and may simply be age-appropriate curiosity and exploration of sexuality. Another theory on exhibitionism was developed by Heinz Kohut in 1971. He believed that one sense of self develops along three axes: grandiosity, idealization, and alter ego connectedness. Kohut believed that displays of grandiosity in childhood are normal and that parents' positive responses to these displays help to form a sense of self and self-esteem. Kohut believed that exhibitionism manifests as a result of absent, dismissive, or inattentive parents. He also believed that children who saw their mothers naked had a higher chance of developing exhibitionistic disorder as they viewed their mother's nudity as permission to display their own naked bodies. Kohut believed that exhibitionists desire intimacy and close relationships but lack the social skills to develop them. Here's a graphic from Potik and Rosenberg 2020, which shows the cycle of exhibitionism developed from Kohut's theory. First, the exhibitionist has unfulfilled exhibitionistic needs. These unfulfilled needs generate negative feelings. The negative feelings create a craving for the mirroring of these urges, which leads to exhibitionistic fantasies that culminate in an exhibitionistic act, which then leads to fantasizing and masturbating over the act. The fantasizing and masturbating only sates the urge for so long, and eventually the exhibitionist turns back into, eventually this turns back into unfulfilled exhibitionistic needs. Not much is known about the persistence of symptoms and distress stemming from exhibitionistic disorder, but most current theories suggest that exhibitionism likely varies with age. As people age, their sexual preferences change and their desire and need for sex decreases. This means that exhibitionism and paraphilic urges likely decrease as one's sex drive and the need for excitement decrease with age. Risk factors for exhibitionistic disorder include comorbid diagnoses of antisocial personality disorder, conduct disorder, and substance use disorder, as well as pedophilic interest. Other risk factors include childhood sexual and/or emotional abuse and hypersexuality. However, most people diagnosed with exhibitionistic disorder deny having been the victim of sexual abuse, so the tie between sexual abuse and exhibitionism is uncertain. Prognosis is dependent on whether the offender admits to exhibitionistic tendencies and/or distress caused by their sexual preferences and desires, whether they view their exhibitionism as problematic, whether they experience guilt, shame, remorse from exposing themselves to non-consenting victims, and whether they have a desire to stop. Prognosis is also impacted by the presence of comorbid disorders such as other paraphilias, alcohol or substance abuse, conduct disorder, and antisocial personality disorder. Potik and Rosenberg identified three main diagnostic approaches to diagnosing exhibitionistic disorder: the unstructured clinical judgment, the actuarial assessment, and the structured professional judgment. Here are some of the assessment instruments used to evaluate people for paraphilias and other disorders. Voluntary phallometric testing is where a clinician or diagnostician hooks the client up to devices that measure arousal in the brain and physical arousal. In men, it measures blood flow to the penis that signals erection. They do this while they show the client videos and photos of various people and situations to measure what causes the subject to become aroused. Potik and Rosenberg stressed the importance of an empathetic approach to the diagnosing, interviewing, and treatment of people with paraphilic disorders. They found that because some clinicians feel morally opposed to certain paraphilias or feel disgusted by the actions of these individuals, they may unintentionally respond in a cold or negative manner to these clients, which decreases the likelihood that these individuals will be truthful about their inner thoughts and desires and makes obtaining enough information for an accurate risk assessment unlikely. They advise clinicians to reframe their mindset about these individuals and to view them as wanting and needing the same things as everyone else: love, acceptance, fulfillment, friendship, but that they do not have the coping skills or social skills to pursue these needs in a healthy legal manner. Clinicians should also be careful to avoid the words deviance and dysfunction when treating clients with paraphilias. I'm going to post the PowerPoint so you can read over this slide, but it gives suggestions for clinicians conducting risk assessments for areas in the client's history to pay attention to and to make sure to ask about when interviewing clients with paraphilias. The DSM-5 does not include any cultural considerations, which is surprising, seeing as the disorder is only considered a disorder if the culture within which the exhibitionist lives views the behavior as taboo and or illegal. Men and women are also conditioned differently by society. Women are less likely to be arrested for exhibitionism, as female nudity is more acceptable than male nudity in the United States. There are places where public nudity is acceptable, and here are some examples. Different cultures have varying social and cultural norms concerning nudity, public nudity, sexuality, and sexual expression. Cultures that do not view public nudity as taboo may not consider exhibitionism to be a disorder. Cultures that view talking about sexuality as shameful may dissuade persons with paraphilias from disclosing their thoughts and any subsequent distress, making diagnosing the disorder more difficult. Sexually repressive cultures may cause more instances of exhibitionism. A good example is Japan, which has high numbers of arrests for exhibitionism and frauderism in response to sexual frustration. Women are more sexualized than men and may not be diagnosed with the disorder if their exhibitionism is socially sanctioned or does not cause general distress. Here is a study that looks at some differences in the statistical prevalence of exhibitionism around the world. It looks at Korea and England, United States, Hong Kong, Guatemala, and here are some statistics. Women are usually not included in studies on paraphilic disorders, as many people believe that women are less likely to have them. However, this study specifically looks at instances of exhibitionism in women and finds that female exhibitionists do indeed exist. A representative study in Sweden revealed that 4.1% of men and 2.1% of women had exposed their genitals in public. Here are some of the treatment methods that have been used to treat exhibitionistic disorder. One is positive psychology and the good life model, which takes a holistic approach to the offender's lifestyle, goals in therapy, etiology of the condition, and treatment. Other types of treatment include positive psychology, which provides clients with the tools to address childhood traumas, negative or failed relationships, and distressing thought and behavioral patterns. Cognitive behavioral therapy and dialectical behavioral therapy can also be beneficial to clients with an exhibitionistic disorder. SSRIs are sometimes used to reduce sex drive and depression, and if SSRIs do not work, drugs that reduce testosterone may be used. Some differential diagnoses that are listed in the DSM are antisocial personality disorder, conduct disorder, and substance use disorders. My case presentation is a 37-year-old man from Baltimore, Maryland. He has been arrested several times for flashing his genitals to women and children. He's been engaging in this behavior for several years, though he has had urges since he was 13 years old. Raymond likes to tie sausages to his genitals for extra shock value. Raymond spends considerable time fantasizing about exhibitionism and planning his exhibitionistic acts. After he flashes strangers, Raymond becomes intensely aroused and masturbates. You can read the rest of this. This character is actually based on a character from the John Waters movie Pink Flamingos. It's extremely graphic, and everything depicted in the film is unsimulated. So if you choose to watch it, do so at your own risk. All right, so here are some of the criteria that Raymond meets. He meets both criterion A and criterion B, and here are some explanations for some of his symptoms. Also, some differential diagnoses for Raymond could be pedophilic disorder, because even though he denies specific arousal from exposing himself to children and denying fantasizing about sexual acts, he does expose himself to minors. He should also be asked about alcohol consumption and substance use, and should be evaluated for fetishistic disorder due to his use of sausages. All right, that is my presentation. Thanks so much for listening. I look forward to reading your responses to my discussion questions, and I hope everyone has a wonderful and safe time over the holidays. Good luck with the rest of the semester. It's been a pleasure taking this class with all of you.